for their employees if they so choose to do so, and then which encourages a lot of money to go to the insurance companies. But if we were to give that money instead of to the insurance companies, give it a portion of it, a significant portion of it, to the individuals as a healthcare savings account to deal with routine expenses and to allow that to grow tax-free, right. Then you'd all of a sudden maybe put the patient more in the driver's seat. And I could see an environment where you'd have more people showing up saying, "Doc, I'm here. I'd like you to be my family physician, and I've got this set up, and I'm ready to pay cash. What are your prices? What will you charge me for this level of care?"
And that's an excellent point. I think that'd be great. The issue that I see is there's no transparency in medicine right now. We don't know what to tell our patients what we're going to charge, because we don't know what the insurance is going to give us, quite frankly. It would be nice if there could just be transparency in prices and say, this is what this costs X, Y, Z, just like when you go anywhere else.
Absolutely.
You know what your
because you know what your costs are.
You know what your costs are. But in medicine, the physician doesn't know, because, like I said, you don't know if you're going to get paid at all.
Right.
So it makes it very difficult that the health savings account, and yeah, as a father and a patient myself, I would like to control my own health care, have my own dollars, and not have someone else make the decisions for me.
Right.
But to do so, you need transparency. Right now you just show up and you have no idea what your bill's going to be.
And even right now, we're this weird in between state, because we do have a high deductible health plan with a healthcare savings account right now, but I can't go to the doctor's office and really shop around and say, well, what will it cost to get this or that done? I actually had to go with Blue Cross Blue Shield because I'm basically using their beating up the providers to get a negotiated rate. So I'm paying whatever rate, which isn't. It's certainly helpful in the current environment to not be paying what might be a sticker price pulled out of wherever.
Right.
But it's not to the best interest of the provider, and it's not to my best interest over the long term, because I should be free to know what different providers think is a fair price for their services.
Exactly, and right now, like I said, our prices are set by Medicare, and once a patient's contracted insurance and the doctor has, you cannot go after the difference. Unlike the dentist, usually the dentist, a lot of them will say, well, here, you pay the $500 up front, they'll submit it to the insurance, and the patient gets back whatever, and if you got back $100, that's it. Right now, what happens to the physician, you submitted a bill for $500, and you get back $100, that's it. You got $100,
right.
And you cannot go after the patient for the remaining balance, and sometimes what you get back, quite frankly, isn't enough to even cover your cost of doing business. So you provided a service, and you didn't even make enough to cover the cost of doing your service. I think transparency is, like you said, you have to know what you're paying.
And it's amazing that so many people think doctors make a ton of money in general. There's this tradition of physicians being highly paid professionals, which certainly does still exist in certain specialties and procedural specialties. But there's also this tendency that there's this question about doctors needing to be of a charitable mindset and giving away charity care. And what I think a lot of people don't understand is that, practically speaking, there is a ton of charity care going on today.
Yes.
Because doctors, we are seeing everybody, but we're seeing everybody without any real understanding of how, if, or when we're going to get paid. And as a result, it's just tough to stay in business without predictability.
No, absolutely. And like I always laugh, I always tell my wife, I wish I made the kind of money people think I made. And that's just not the case. And I think people need to realize that there is a big difference between primary care physicians, family docs, internists, pediatricians versus the subspecialists and surgeons. It's very different, the compensation system. And what also people, and I know people don't feel sorry for doctors, I don't expect them to. What they need to realize too is, first of all, comparing doctors and attorneys, physicians will go to postgraduate school for 4 years. Attorneys go for 3. The average attorney graduating from UNC after 3 years starts with a $100K salary. The average physician, which people understand, after 4 years still needs to go into training, and it could be a minimum of 3 years for primary care to probably your neurosurgery, 8 years or whatever it is. And so during that time, you're not making $100K. You're maybe making $30,000 a year.
Absolutely.
So you're postponing getting paid while your peers are making money, and then you not only do you graduate with loans from college, loan from medical school, not only did you make not enough to even make a living for 3 years or more, then you're expected to open up your office, and then you take out more loans, and that's when you get in trouble.
That's
So-
a huge point, and I'm glad you brought that up because I really saw the bad side of that, and I think a lot of people don't realize the debt burden that people come out of.
They have no idea the debt burden. I think they say the average debt burden now is like $250,000, and so part of it is the government that says we'd like more minority positions. Well, there's two issues. One, and they want them to be primary care. Usually the minority kids are underprivileged to begin with, so you can't expect them to go through all that training and then owe the kind of money they're going to, and then want them to go into primary care because they realize the physicians are never going to make their money back. So what's been happening with minority students is they're just not going into medicine, number one. They're going to do something that's going to be a lot easier and quicker. And two, if they do go into medicine, they're not going to become primary care docs. They're going to become proceduralists, so they can pay off those loans a lot quicker.
Mm-hmm.
And so it's defeating the purpose. And right now, there's a shortage of physicians, especially a shortage of primary care. We're filling our residency positions with foreign medical graduates. There's not enough U.S. doctors filling those spots. The kids graduating from medical school today are going into the surgical subspecialties for all the reasons that I talked about. So we're filling our need with foreign medical graduates. And even though now, even if we increase the number of medical schools or medical students, I think all you'll do then is not increase the number of doctors. You'll just replace the foreign medical graduates with U.S. grads in those primary care positions. So I would think that we'd have to have a shift of our thinking and our compensation system, the way it currently is set up, if we do want more primary care physicians,
mm-hmm.
and if we want more minorities to become primary care physicians.
Sure, sure. Well, it's great to get all these issues out on the table, and I appreciate you taking the time to discuss them. Have you run into any other physicians, or have you talked to any physicians who have kind of tried to check out of the system and say, you know what, I'm going to do a completely low overhead practice. It's not necessarily going to be a retainer or boutique medicine. It's just going to be, look, here are my prices, cash on the table, and it's me and my cell phone and a stethoscope.
It's still, yeah, there's local physicians that I've seen. There's one I can think of that has a cash-only model. And then, of course, you have your physicians who do the retainer, concierge, or boutique medicine like you described. And then I've seen physicians also completely go out of primary care and maybe do like more cosmetic type things or
mm-hmm.
weight loss clinics where it's again cash on the barrel. And then I've seen some physicians get out of medicine altogether and become pharmaceutical reps or sales reps or something along those lines. So no, yes, I have seen that.
A lot of challenges.
A lot of challenges. What they do in children's health initiatives and everything. I think somehow they have to lessen the administrative cost and maybe having community centers, something along those lines where those patients will go somewhere. I think the country has to invest in medical research and invest in training programs. Training programs receive federal dollars. They can train future residents, and that's part of sometimes where I hear there's going to be cutbacks being made.
Sure.
So I think you need to fund future physicians, and I think the whole relative value unit system of the way compensation models are made now need to change. Now my surgical subspecialists and other specialists are not going to like saying, they need to make less money in primary care and make more. I'm not saying that, but somehow has to be a little more equitable. If you want family physicians and you want minority physicians, you have to pay enough to stay in business. So my answer is, and it's not a simple solution, is you have to have, I think, the current system a little bit of everything, and maybe eliminate some of the administrative costs. But I would target, if it were me, it'd be the insurance companies number one.
Mm-hmm.
They're making record profits, and I think that the last 2 years, pharma companies and insurance companies have been the biggest lobbyists to the government. I think it's been $500 million, if I remember the numbers correctly, and what they push forth to keep things the way they are. So I think you need to, we didn't even talk about the cost of medications and stuff.
Right.
That's a whole nother issue. We could spend another half hour talking about that. So I think patients need to be able to get their medicines. I think some of the pharma companies keep repeating the same formulations just to continue the revenue of their patent.
Yeah.
They say it's a different isomer or a different metabolite, or basically it's the same medicine, but it's an extended release version as opposed to